Welcome to the ISTH webinar series. I'm Dr. Sarah Vesely from the University of Oklahoma in the United States, and I will be moderating today's webinar. Today, we will be discussing TTP guidelines with Dr. Long Zhang and Dr. Spiro Cataland.
I'm Long Zhang from University of Kansas Medical Center, Kansas City, Kansas. Our first presenter is Dr. Sarah Vesely, who I've known for many years. Dr. Vesely is the David Ross Boyd Professor of Biostatistics at the University of Oklahoma Health Center. She's also Associate Dean of Academic Affairs in the Hudson College of Public Health and the Director of Biostatistics and Research Design Sharing Resource at Stevens Cancer Center. Dr. Vesely is a biostatistician who was experienced in systematic review, guideline development, clinical trial, and evidence-based medicine. Throughout her career, a major part of her research has focused on clinical problems in hematology, particularly the development and analysis of Oklahoma TTP registry. She has published over 170 peer-reviewed manuscripts, taught 40 different courses, and served as a mentor for over 65 graduate students. And Dr. Vesely has served also in many national and international committees. Please welcome Dr. Vesely.
Thank you, Dr. Zhang. So today I'm going to talk about the methodology we use to develop the guidelines, the grade methodology. First, I would like to acknowledge our panel members. We had an international multidisciplinary panel. The clinical co-chair was Dr. Long Zhang, who's a pathologist in the United States, and I was the methods co-chair. We had 2 patient representatives from the United States and 8 additional physicians that are listed on the slide. Their specialties included, of course, hematology, but also nephrology, intensive care, and neurology. I want to thank all the panel members again for all of their hard work. I'd also like to acknowledge our methods team. So our methods team was from McMaster in Toronto, Canada, and this was led up by Alfonso Ioria and Menica Pa, who are experts in grade and guideline development. And so their team created all the evidence tables and did the systematic reviews. So they were an extremely important component of our work. So what did the guideline process actually look like? We use the GRADE methodology, and GRADE stands for the Grading of Recommendations, Assessment, Development, and Evaluation. So the GRADE working group has developed, evaluated, and implemented a common, transparent, and sensible approach to grading the quality of evidence and strength of recommendations in healthcare. So the panel was selected and balanced in terms of expertise, conflict of interest, and of course we wanted it to be international. The first meeting was held in June of 2018, and the goal was to create PICO questions and also decide the most important outcomes of interest. Then, between meetings, the McMaster's Methods team conducted an extensive literature search and compiled many, many evidence tables. At the second meeting in May 2019, the panelists had seen the evidence tables, and we came together to evaluate that evidence as a group and use the evidence to decision framework to guide our recommendations. So I think everyone's probably familiar with what a PICO question is. So an example of a PICO question from our guidelines was, should therapeutic plasma exchange plus corticosteroids versus therapeutic plasma exchange alone be used for patients with immune TTP experiencing the first acute event? So in this example, the P, or population of interest, is patients with immune TTP experiencing the first acute event. The intervention is the therapeutic plasma exchange plus corticosteroids. The comparison is the therapeutic plasma exchange alone. The outcome, it was not explicitly listed in this question since we had a list of outcomes we were evaluating. So here's our list of outcomes we were interested in. And we rank these outcomes from most to least important. So the most important outcomes were all-cause mortality followed by all cardiovascular events and stroke, TI, or clinically obvious neurodeficit. Other important outcomes included platelet count recovery, relapse and the time to relapse, as well as acute kidney injury and dialysis. We were also interested in days in the hospital or days of therapeutic plasma exchange, as well as exacerbation and normal ADAM-TS13 level. Conflicts of interest is an important component of creating a transparent guideline process. All potential panelists were screened so that the panel would be comprised of at least some non-conflicted members. Members were asked to disclose all financial and non-financial relationships from 12 months prior to the guideline initiation through to publication. Financial conflicts included commercial entities with interests related to guideline recommendations, like working with pharmaceutical companies who had TTP drugs, and also non-financial conflicts, such as the involvement in TTP or TMA research. So how did we handle that conflict of interest during the meetings? Well, during both meetings, the panelists were reminded who had conflicts, and the conflicts of each individual panelist were declared verbally and presented on screen at the start of the discussion. Individuals with major conflicts of interest with respect to the individual PICO questions were required to abstain from the formulation of those questions in meeting 1 and the voting for those corresponding recommendations in meeting 2. They were, however, allowed to contribute to the discussion leading up to the final vote. So McMaster's, as I mentioned, really did the lion's share of the evidence production. So they were the ones that were in charge of reviewing the evidence and compiling these tables. So they did an extensive literature review and systematic review and created these evidence profiles. During the second meeting, we followed what's called the evidence to decision framework during the meeting, and we created evidence to decision tables. So I'm sure many of you don't really know what evidence to decision table means. So what we wanted to do was to ensure that we followed the same framework and asked the same questions for each PICO question when we then created a recommendation. So what we did first was we evaluated both the desirable effects as well as the undesirable effects. So for example, will the intervention reduce deaths, which would be desirable, but cause bleeding, which would be undesirable? So the panel evaluates the evidence table and decides how substantial the desirable effects are. Are they trivial, small, moderate, or large? Perhaps we don't know based on the evidence available in the literature, or perhaps the effect varies. We decided this for both desirable and undesirable effects. Then the panel weighed in on the certainty of the evidence. So how certain were we that these effects we were seeing were real? We could decide that they were very low certainty, moderate, or high certainty, or we could have chosen that there are no included studies. So remember that high quality evidence would include things like randomized clinical trials, and lower evidence are cohort studies with no comparison group. Then we made decisions on whether there's important uncertainty about or variability in how much people value the main outcome of interest. So patients tend to value outcomes more for outcomes like relapse or exacerbation rather than survival. So after we gathered all this information, then we used this to decide if the balance between the desirable and undesirable effects favor the intervention or the comparison. So we could decide it favors or probably favors either the comparison or the intervention, or we could decide that it does not favor either. So now that we've made a decision based on the evidence, we can also weigh in on some other issues. Those other issues include the resources required. So how large are the resources required to implement this intervention? And how certain are we of those resource costs? This is an international guideline, so of course, how drugs are paid for and how interventions work across different countries, of course, can vary a lot. We also look for cost effectiveness studies. And we looked at equity. So if we chose this intervention, would there be an impact on health equity? We also discussed how acceptable the intervention was to key stakeholders. And those key stakeholders include patients, physicians, payers, hospitals, etc. And then the last thing we discussed was feasibility, if the intervention was actually feasible to implement. After we went through all of these questions for the PICO question under discussion, then we got to grading the strength of the recommendation. And there were two options. They were strong or conditional. If it was a strong recommendation, then the guideline panel recommended that this event happen. And that meant that the panel was confident that the desirable effects of the following recommendation outweigh the undesirable effects. We also thought that most patients would accept the recommended course of action, while only a small portion would not. A strong recommendation also means that most clinicians should follow the recommended course of action, and the recommendation can be adopted as a policy in most situations. Strong recommendations are usually based on high quality evidence in which we have high confidence. There are some instances when we can make a strong recommendation based on lower evidence. This can occur, for example, when low quality evidence suggests benefit in a life-threatening situation. On the flip side, if we made a recommendation conditional, then the guideline panel would suggest this action. A conditional recommendation means that the panel believes that the desirable effects of the following recommendation probably outweigh the undesirable effects. We think that most patients would accept the suggested course of action, but many would not. For conditional recommendations, decisions aids might be useful in helping patients make decisions in a way that's consistent with their value and preferences. Clinicians should note that different choices will be appropriate for different patients. We usually don't create policies on conditional recommendation because of the nature of the recommendation. So this was how we made the decision. So for each recommendation, there was a report of the systematic review of the literature, an evidence profile summarizing the evidence appraisal, and a comprehensive evidence to decision table. And these will be available online when the guidelines are published. So now that we have discussed how the methodology was used to create these guidelines, we'll actually proceed now to the true recommendations. So the second presenter is Dr. Zhang. Wang Zhang is a professor and department chair of pathology and laboratory medicine at the University of Kansas Medical Center in Kansas City, Kansas. He is an NIH-sponsored investigator and a world-renowned expert in diagnosing and management of thrombocytopenic purpura. Dr. Zhang was among the first scientists who identified and cloned ADAMTS13, a critical blood enzyme that is severely deficient in patients with TTP. Dr. Zhang's team has published more than 100 manuscripts in peer-reviewed journals. Most of them are about pathogenesis and novel therapeutics of TTP. Dr. Zhang is currently the associate editor for Journal of Thrombosis and Hemostasis and the Archives of Pathology and Laboratory Medicine, as well as a member of the Hemostasis Study section of the National Institutes of Health. Moreover, Dr. Zhang has trained more than 24 scientists and physician scientists who have gone on to establish their academic career around the globe. It's my honor to present Dr. Zhang, who will be discussing key diagnostic recommendations for the TTP guidelines. Let's continue.
Thank you, Dr. Besley, for your nice introduction. So what I'm going to talk about is TTP. So you probably all know what is TTP. And TTP is a rare but potentially fatal blood clot disorder. The incidence is about 2 to 6 per million residents. And TTP is caused by severe deficiency of ADAMTS13 activity, resulted in formation of microvascular thrombosis throughout the body. The deficiency of ADAMTS13 may be caused by a mutation in ADAMTS13 gene known as a hereditary or congenital TTP, and in short called CTTP. And it may also be resulted from acquired autoantibody against ADAMTS13, known as immune TTP, also called iTTP. So the clinical presentations include severe thrombocytopenia. Most patients will have a platelet count of less than 30,000 per microliter, and also have a microangiopathic hemolytic anemia, which means the patient have a low hematocrit or hemoglobin, and the presence of a schistocyte in the peripheral blood smear, also low heptoglobin, and increased the LDH. And also the Coombs test usually is negative. And most patients will have normal to mildly abnormal coagulation testing profile. And some patients will have various degree of organ damage. Some patients could have a myocardial infarction, and other patients could have ischemic stroke. And so this kind of clinical presentation overlap with another syndrome called a hemolytic uremic syndrome, we call HUS. And this mostly resulted from E. coli, sugar-toxin producing E. coli, and particularly in pediatric population, the children are younger than 5 years old. And also in adult, it can also be caused by over activation of a complement cascade. And so the distinction between TTP and HUS clinically sometimes can be very challenging. And so the good news is we have this ADAMTS13 now can be measured in these patients. So what is ADAMTS13? So ADAMTS13 is a plasma metalloprotease, which is actually a large multimeric protein shown on the left side. And it consists of a protease domain, and this is the business center, and also a very long, the C-terminal domain, which actually interact with the substrate or some other function as well. The only known function for ADAMTS13 is to cleave a von Willebrand factor called VWF. And VWF is a protein that are released from activated or injured endothelial cell, and usually will release and then anchor on the cell membrane. And when that happens, the ADAMTS can cleave and remove them from the membrane. And once it's released into the bloodstream and under shear stress, this VWF can be elongated. And this elongated VWF and then can also be exposed to ADAMTS13, and ADAMTS13 can cleave them and may leave the VWF as kind of small, but hemostatic, but it's not prothrombotic. If ADAMTS13 is deficient, whether it's caused by mutation on the ADAMTS13 protein, or it's caused by autoantibody, then this function cannot be performed, and von Willebrand factor become elongated, and it's called the ultra large von Willebrand factor. And this kind of von Willebrand factor is very sticky and hyperactive, and they can actually capture the platelets flowing through the blood and cause platelet-rich microvascular thrombosis. And this actually causes organ ischemia and resulting in death. So of course, the treatment is actually trying to remove the antibody and or suppress the antibody production. And nowadays we have a new drug that Dr. Catalan will present to you, and Caplacizumab can actually disrupt the platelets and the von Willebrand interaction. Would be another way to treat TTP. So the panel has actually decided to look at the three relevant diagnostic pathway and all around the importance of having an ADAMTS13 measurement. So the scenario A will be a pathway where ADAMTS activity measurement is readily available, usually within 3 days. The scenario B will be ADAMTS13 is not available no matter where it is. So, and scenario C will be ADAMTS is available, but it will be delayed. So like some community hospital, they actually have to send out. Okay. And with this 3 different scenario, so there will be different pathway for the diagnosis and early management. Okay, before you do all the ADAMTS tests, of course, you can actually use some of the clinical parameter to determine the likelihood of the patient have a severe ADAMTS deficiency will be defined by less than 10%. And there's a French score or plasmic score that can predict that. And basically, French score and the plasmic score are essentially identical, with the first parameter will be platelet count, and usually less than 30,000 per microliter. And creatinine is elevated, but it's not very high. So usually less than 2 or 2.25 milligram per deciliter. And the other parameter is actually in the French score is pretty much assumed that these patients does not have cancer, does not have a bone marrow transplant or solid organ transplant. And yet in the plasma score, they actually giving 1 point for each one of those parameters, except that the MCV, which is present in the plasma score, but is not in the French score. But overall, you can see the French score is about 4 points less than the plasmic score, but the predicted value seems to be similar. Okay. So with that kind of clinical predicting, and so if the patient in the setting of a patient have a high probability, and also with immediate or timely access of ADAMTS test, when that situation, if this patient is in this situation, you start the plasma exchange and corticosteroid right away. Okay, and so you don't necessarily have to wait for ADAMTS13 test to come back, but you do collect the ADAMTS13 before you start the plasma exchange. So like a scenario A or scenario B, A will be you will have a result within 3 days, or B will be having result after 3 days. And no matter what, if this patient had a high probability of having immune TTP, you do start the plasma exchange, corticosteroid, and Caplacizumab, okay, and without waiting for the ADAMTS13 to come back. So when the ADAMTS13 result does come back, and you look at the result, if the ADAMTS13 is less than 10% with positive inhibitor, you continue Caplacizumab and also adding the Rituximab. So, and if the ADAMTS13 comes back with greater than 20% or normal, and you actually stop Caplacizumab in this case and consider other diagnosis, okay? If the ADAMTS13 is kind of a borderline, in between 10 to 20%, and I think the panels suggest that we use clinical judgment to guide the treatment, because there's still a lot of things that we don't know yet. So the other scenario, the recommendation number 2, is in the setting of the timely access ADAMTS13 and patient with intermediate or low probability of having immune TTP, and you still consider plasma exchange and corticosteroid, but you don't start with Caplacizumab. You wait, so you order ADAMTS13 test and wait for ADAMTS13 result to come back. Okay, And if ADAMTS13 tests less than 10% or with a positive antibody, you now add Caplacizumab and also consider Rituximab, okay? If ADAMTS13 tests activity greater than 20% or normal, and you do not add Caplacizumab this time, and consider other diagnosis as well. If ADAMTS13 test is the borderline, so between 10 to 20%, and the clinical judgment is required to guide the additional therapy, also should consider other diagnosis as well. Okay. So the recommendation number 3 is actually if you don't have any access to ADAMTS13 test. Okay. In this scenario, then you still do plasma exchange and corticosteroid, but you don't use Caplacizumab. So that's what the recommendation is. Okay. So in summary, so this is the first evidence-based guideline developed by the ISTH guideline panel for the diagnosis and the early management of TTP. Okay. The diagnosis of TTP rely on high index of suspicion based on the clinical presentation and laboratory result, and as I mentioned, with either French score or plasmic score that can be used. The panel recognized, of course, the importance of having ADAMTS13 test in the initial diagnosis and the management process. The availability and the turnaround time of ADAMTS13 may directly affect how we manage those patients with suspected immune TTP. So, of course, all these recommendations are issued as a conditional in the context of a low certainty of evidence. Therefore, further research is necessary to develop a more rapid or accurate ADAMTS13 test and to more broadly assess how ADAMTS13 tests can really impact clinical outcome. Thank you.
Thank you, Dr. Zhang. As a reminder, we will address all questions after both talks have concluded. Next, we have a presentation from Dr. Cataland. Dr. Spiro Cataland is a professor of internal medicine in the Division of Hematology at Wexner Medical Center at The Ohio State University. He is also the director of the Benign Hematology Program at Ohio State University. Dr. Cataland's clinical and research interests include thrombotic thrombocytopenic purpura and atypical hemolytic uremic syndrome, with an emphasis on immune-mediated TTP. Dr. Cataland directs the Biomarkers Reference Laboratory at Ohio State University that performs correlative laboratory studies for ongoing research. Dr. Cataland has a long-standing interest in novel therapeutic approaches to iTTP, as well as an ongoing research emphasis to better understand the development of long-term complications in patients with a prior history of TTP and the mechanisms for their development. Dr. Cataland has also worked to establish the United States Thrombotic Microangiopathy Clinical Consortium, an organization of over 15 academic medical centers across the United States that was organized for the purposes of conducting collaborative research in TTP and AHUS. Today, Dr. Cataland will be discussing key treatment recommendations from the TTP guidelines.
Thank you, Sarah, and thank you, Long, for both of your presentations. So what I'd like to do is highlight some of what I think are the more relevant or important to clinicians recommendations on treatment from these ISTH TTP guidelines. So you might ask the question, TTP guidelines, why are they needed and who needs them? But really the advances in the field make these really important and relevant these days. Since the publication of the previous TTP guidance documents from the UK group and from Japan, there have been significant developments in the treatment of TTP. There are certainly new treatment modalities, including Caplacizumab, that I'll talk about in just a little bit, as well as other multiple treatment options that need to be prioritized that may be synergistic, could be sequenced, and really the questions are being asked how to most appropriately use these. There are emerging approaches and special situations that may require additional specialized care or expertise. And this includes the ADAM-TS13 deficiency in remission in a patient with a prior diagnosis of TTP. As well as a very increasing issue of TTP, ADAM-TS13 deficiency in pregnancy, in a woman who wants to get pregnant, who already is pregnant. And there are certainly some relevant issues that need to be discussed and addressed. The question of who really needs these TTP guidelines is more than just hematology and pathology. Multiple specialties may be involved with the plasma exchange therapy, including nephrology, but there's certainly also long-term complications that involve kidney disease, cardiac disease, obstetrics, as we've already mentioned, and some of the long-term complications that we're seeing in patients with TTP really beg the involvement of neurology in the care and long-term care, especially of patients with TTP. So the first thing I'll discuss is the issue of rituximab and its use in iTTP treatment, and we'll lump recommendation 2 and 4 together for the purpose of this discussion. So for patients with ITP experiencing their first acute event, as well as recommendation 4 for relapse, the panel suggests the addition of rituximab to corticosteroids and plasma exchange over corticosteroids and plasma exchange alone. So this is a conditional recommendation in the context of very low certainty evidence. This low certainty evidence really stems from the fact that the data informing these decisions in these 2 cases are from non-randomized trial, usually using historic controls. As you can see in the right, some of the data published from the UK group and Marie Scully's group in London looked at relapse-free survival in patients who had early initiation of treatment for rituximab in acute TTP. Nearly all of these patients were newly diagnosed, but you can see in the solid line the treated patients with rituximab, and the dashed line the non-treated, the historical controls who they were compared to. And you can see the difference in relapse survival going out now several months, 40, 50, and 60 months. So very clearly, rituximab appears to prevent or delay relapse of TTP. I think that's apparent from these and other data from the French group as well as others. There's certainly this suggestion that maybe other subsets, racial differences, non-ICU patients, that the rituximab may shorten the hospital stay, may shorten the length of plasma exchange required, but these were not seen in the large group completely and just from subset analyses, and therefore can't be relied upon as much. So very clearly the benefit of rituximab is preventing relapses. This conditional recommendation is based upon issues potentially with the expense of the medication for some patients and providers. And if this is a newly diagnosed TTP patient, the question really can be asked, is this patient ever going to relapse? Did they even need this for the upfront patients? Maybe there's a stronger rationale in the relapse patients who've already demonstrated this relapsing phenotype. There should also be a consideration for patients with coexisting autoimmune diseases, where treatment with rituximab may be more relevant to addressing both issues in that patient. A related issue is the preemptive use of rituximab in iTTP in remission. And recommendation 6 from the panel states for patients with iTTP who are in remission, but still have low plasma ADAM-TS13 activity, but no clinical signs or symptoms of relapse, the panel suggests the use of rituximab over non-use of rituximab for prophylaxis or preemptive therapy. The data suggests that preemptive rituximab therapy will prevent or delay relapses, as we saw previously with the data from the London group, and have a longer time for iTTP relapse. And you can see this in the figure on the right here, showing the follow-up and the relapse-free survival. In the red, it's the prophylactic rituximab or preemptive rituximab treated patients, and in the blue, historical controls. In this study, ADAM-TS13 activity was measured every 3 months, which informed the decision of when to use the rituximab preemptively, typically when it was less than 10% as reported in this study. And this will be the source of another good practice statement we'll talk about toward the end of the presentation. Again, though, these were non-randomized data. There's no clear effect on survival. There's the potential issue of expense, And there's certainly a patient commitment necessary for the serial ADAM TS13 monitoring to inform this decision to know when retreatment might be required. The panel also noted that rituximab prophylaxis without ADAM TS13 monitoring is not an evidence-based strategy and can lead to excess treatment or over-treatment in patients. Recommendation 5 addresses the newest treatment, Caplacizumab in iTTP. For patients with iTTP experiencing an acute event, a first event or relapse, so it's not differentiated in the guidelines, the panel suggests using Caplacizumab over not using Caplacizumab. This is a conditional recommendation in the context of moderate certainty evidence. So the data informing this recommendation are from 2 randomized prospective placebo-controlled trials. Now, it should be noted that the mortality rate was low in both arms, in the Caplacizumab treated arm as well as the placebo, suggesting there was less severe disease across all enrolled subjects on both arms of the study, which might be expected in a prospective study. What we're seeing in these studies, though, was a clinically significant reduction in the exacerbation rate or the recurrence rate in the first 30 days after the last plasma exchange procedures. In the first study, especially, relapse rates were increased, really likely a function of the end of the Caplacizumab dosing, which protected the patient throughout the exacerbation time period or 30 days. But after the Caplacizumab was stopped and there was persistent ADAM TS13 deficiency, recurrences of TTP occurred. This really addresses the fact that the Caplacizumab is not a disease-modifying treatment, but really an adjunct to the existing treatment and immune suppressive therapy to treat this unresolved ADAM TS13 deficiency, which leads to the clinical phenotype of TTP. There were clinically important but manageable bleeding side effects seen in these patients as well. So it's important to understand the mechanism of action of Caplacizumab and emphasize the fact that it's not modifying the disease. Caplacizumab targets the A1 domain of VWF that interacts with platelets. So it prevents the downstream effects of TTP. It prevents the formation of these microvascular thromboses that really mediate the clinical phenotype of the disease. The panel felt the greatest benefit was when the earlier administration of Caplacizumab rather than the later administration. But there are certain caveats that need to be mentioned. This conditional recommendation was based upon a clinician's ability to rapidly identify iTTP with a high likelihood of success, really experience with this disease. It is really required that you have timely and reliable ADAM TS13 testing, both to confirm this initial diagnosis of iTTP, but also to inform the decision on the length of therapy with Caplacizumab during follow-up. It should also be emphasized that Caplacizumab should be used by an experienced clinician with an understanding of this unique mechanism of action. So an experienced clinician understanding the medication as well as the disease itself. Recommendation 9 deals with iTTP in remission and pregnancy, which is an increasing issue in patients as we now have patients surviving longer and living normal lives. So for patients with iTTP who are pregnant and have decreased plasma ADAM TS13 activity, but with no clinical signs or symptoms of TTP, the panel recommends prophylactic treatment over no prophylactic treatment. And this is a strong recommendation in the context of very low certainty evidence. Certainly it's understood it's very difficult to do prospective randomized studies in pregnant patients, but there are increasing and mounting data that suggest pregnant women who have concurrently severely deficient ADAM TS13 activity may have poor outcomes with the pregnancy. There's not enough data to really make any specific recommendations on specific regimens to treat this ADAM TS13 deficiency. But the strong recommendation for prophylaxis in the absence of moderate to high certainty evidence really stems from the fact that this intervention may reduce maternal and infant mortality rates. The risk-benefit of specific regimens, though, requires further study before specific recommendations can be made. But in general, the benefits of treatment appear to outweigh the risk in patients with a history of TTP, ADAMTS13 deficiency, and pregnant. So TTP and long-term follow-up, it's more than just preventing relapse, I think, is a theme that comes through these panel recommendations. And these good practice statements should be noted are not based on a formal review of the evidence, but rather are a snapshot of the care provided by expert TTP healthcare providers. So it may be based on limited high certainty evidence, but the evidence suggests the certain benefit of certain actions. And we'll talk briefly about the long-term complications of TTP and the idea of ADAMTS13 activity monitoring and remission in iTTP patients, as you've already heard about in the context of Rituximab and Caplacizumab therapy. So supportive care, good practice statement 10 deals with these long-term complications of TTP. And the data and the figure on the right are from the Oklahoma group. And looking at the probability of death in patients with a prior diagnosis history of TTP compared to Oklahoma and US norms. And what was found in this very interesting study and quite sobering study was that there was an increased probability of death in patients who had a prior history of TTP. If you look deeper at the deaths and how they died, it's not easily attributable to TTP in all cases. And in fact, the majority have other causes, suggesting cardiovascular or other related conditions that may have led to death. The study also noted issues with mood disorders, neurocognitive symptoms, including short-term memory, and hypertension being significant issues, raising the question and the importance for it, raising the point that long-term follow-up for these long-term complications may be more important in patients with TTP. So this routine follow-up every 3 months is more than just the ADAMTS13 monitoring that we'll talk about next, but to monitor and intervene to prevent some of these long-term complications and issues. So we've already spoke about ADAMTS13 activity monitoring in remission, and this is dealt with in supportive care good practice statement 13. ADAMTS13 activity monitoring in remission, patients should be assessed regularly during follow-up. Now, the literature on ADAMTS13 monitoring and remission was not reviewed. There's no specific recommendations that can be made that are evidence-based, but expert opinions suggest from the panel that patients should usually be assessed monthly for the first 3 months after their initial treatment, every 3 months for their first year following, and then possibly every 6 to 12 months during long-term follow-up. ADAMTS13 activity, as well as clinical monitoring for these long-term complications, should occur at each visit, but more frequent measurements of the ADAMTS13 activity should be obtained if declining ADAMTS13 activity is noted, as it may inform decisions on relapse prevention. Interpretation of the ADAMTS13 activity can include a stable and durable ADAMTS13 activity near the level of normal would be reassuring to clinicians and predicting a lower risk of relapse in the next 3 to 6 months. Persistently low levels of ADAMTS13, especially less than 10%, and maybe as less than 20%, may place patients at a greater risk for relapse. This risk is not absolute or uniform, but I think the data suggest that the risk of relapse is increased when there is severely deficient ADAMTS13 activity. And with that, I'll stop. Thank you.
Thank you. Thank you, Dr. Catalan. We will now begin the question and answer session. So first of all, someone asked if we were recommending collecting the sample for ADAMTS13 after the initiation of plasma exchange. And I'll go ahead and answer that no, we're recommending you take the sample as soon as possible. And then our diagram represents the fact that you're going to make a treatment decision to initiate plasma exchange before you're going to know the result of that test in most cases. Dr. Zhang, there were several questions around when should you do antibody test? Should you do this for all suspected patients, or would you wait to perform the antibody test for those who are confirmed TTP patients? And there were several questions about which ADAM-TS13 test we should be using.
I see. So in terms of when do you do antibody testing, of course, you want to measure activity first. If activity is normal, then you don't do antibody test. If activity is less than 30%, in most center will actually reflex to start to do antibody test. And usually start out with inhibitor, which is inhibition of the ADAM-TS13 activity. And then if that is not sensitive enough, and you can actually, if this is negative, you can actually do the IgG test using ELISA base.
Okay, thank you.
And in terms of the methodology, I think in most places using the fluorescent energy transfer assay called FREDS, but there's also a different assay using ELISA-based measuring the specific cleavage site by a monoclonal antibody. So there's many different methodology. These two seems to be the most common.
Excellent. Dr. Zhang, there's another question about the scenario in which ADAM-TS13 testing is not available. And they were wondering if the recommendation regards only Caplacizumab. What about Rituximab? Should it be considered or not?
So the recommendation right now says you can start with a plasma exchange and corticosteroid. If you don't have ADAM-TS13 test, we do not recommend that you use Rituximab and Caplacizumab.
Excellent.
Because you don't really know what we're dealing with.
Here's a question for both Dr. Zhang and Dr. Cadlin. What do you think about the ability of Caplacizumab to overcome prognostic factors for early mortality and iTTP? Is there a specific study that proves it?
I can certainly start with that one. I mean, certainly what's notable in the last 20 to 25 years of TTP, I think, is despite the improvement in really all phases of care, plasma exchange, immune suppressive therapy, we really have not been able to get rid of this 10 to 20% persistent mortality rate. This wasn't shown in the randomized studies, the mortality difference, but I think primarily because of the decreased mortality rate across all those patients. There's a combined analysis that suggests there is a significant difference in the mortality. And I certainly believe that the Caplacizumab really stands a very good chance of really impacting this mortality, just based on its mechanism of action and its ability to maybe block the microvascular thrombotic events that lead to the mortality in refractory TTP patients. So I think the potential is there.
Excellent.
I have to agree, actually, even though we don't have any study, but I think this is something we should actually looking into that in the future once patients start to use this, to see the mortality is actually reduced significantly overall.
Excellent. So there's a couple of questions, Spiro, around pregnancy, about what recommendation you would use for pregnant, if you're pregnant and you have iTTP, and what would you treat pregnant women with who had low ADAM-TS13? Would it be steroids, pheresis, Rituximab, Caplacizumab? And what was the evidence to make this a strong recommendation?
Well, the strong recommendation really comes with the understanding that there was limited high quality data, but expert opinion and again, more limited data. I think the treatment of an acute TTP episode in pregnancy really should be treated very much similar to any other TTP episode, with the caveat that Caplacizumab has not been studied in pregnancy, and Rituximab could be used potentially, but maybe more problematic. I think the bigger issue is the patient with, and the bigger question mark for physicians and patients is the patient who has undetectable ADAM-TS13 activity, a history of TTP, and they're presently pregnant. I think that the small, but I think significant data that we have from a couple different centers suggests that if you have undetectable ADAM-TS13 and you're pregnant, relapse, unfortunately, is going to be inevitable, it appears. plasma exchange and steroids throughout a pregnancy really is not a tenable situation. In congenital TTP, it can be plasma infusion. There are some limited reports of the use of cyclosporin prophylactic in pregnant women, really stemming from its use in transplant patients for many years. There's differing opinions on rituximab and when can it and if it can be used in pregnancy. But in the context of ADAMTS13 deficiency and a history of TTP, it certainly might need to be considered. I would really emphasize that it's the involvement of maternal fetal medicine and expert opinion on that side, the obstetric side, along with hematology and other subspecialists, really should be involved in these patients together collectively.
Right. And I think, part of the strong recommendation also came just from the caveat that we had low quality evidence in this life-threatening situation, right? So that
Yes.
there's often, problematic. We had several questions around monitoring of ADAMTS13 during remission. So Spiro, would you like to address that question? How often do you monitor the activity in the inhibitor? Should we be worried about the turnaround of the assay in remission?
Those are certainly all going to be issues. It's the testing, it's the travel to the clinic to get that testing. But I think there's increasing evidence that it's important to monitor patients regularly. The ADAMTS13 activity for preemptive therapy to prevent relapse. But I think equally important to pick up and try to address and prevent some of these neurocognitive issues, vascular issues, potentially cardiac or neurovascular issues that I think are relevant in these patients that need to be addressed. The recommendations, I should say, the good practice statements are every 3 months and maybe going out to every 6 to 12 months. I think the specifics of 3 or 6 months are going to be a function of patient and physician concern, length of travel, their history, time since their last event will temper all these things. But I certainly believe a patient who has had one TTP episode in the past, no matter how long ago, deserves to be followed long term.
Excellent. We had one question about the difference between acquired and iTTP or immune TTP, and I think we're using those terms interchangeably here. Let's see. So Dr. Lemley asked if it was just better to have rapid, widely available ADAMTS13 instead of having to use this prediction score. Dr. Zhang, do you want to respond to that?
Yeah, I can see his point, but I think as a clinician, clinical presentation and how patients doing is also very important, right? You're having ADAMTS deficiency. In some cases, they have no disease.
Yes.
So.
Yeah, I think you're, Professor Lemmy is exactly right. You should need. I think these prediction models aren't an argument for not needing the ADAMTS13 testing, but these prediction models are very good at 10 o'clock at night when you're seeing the patient and you're deciding, do I start plasma exchange or not? That's really the relevant question that no one's going to have within the hour ADAMTS13 activity. There are some certainly colorimetric tests that give you a quick readout. But I think these prediction models really give you the ability to predict the likelihood of ADAMTS13 activity and start plasma exchange or not until you get that activity back, ideally the next day.
Excellent. So here's another question. How often is suggested for the ADAMTS measurement or measurements of ADAMTS13 activity during treatment, and especially after plasma exchange until they reach more than 10%? So how often are you monitoring patients during their acute phase of treatment?
I don't think there's any specific guideline for that, and we certainly have started to look at this almost like now 20 years ago. So for patients who had antibody, mediated, ADAMTS deficiency, even you start a plasma exchange, the LMTS13 is not going to come back right away. Only a small fraction of patients, the LMTS13 comes back over time, within a week or two. But most patients will actually have a low LMTS13 for a long time. And so whether you should measure them every 3 or 5 days or once a week, I think at least we have a paper just published 2 or 3 months ago in Blood Advances showing that before patients send, before we send patient home, before we discharge a patient, we should always get an MTS13 activity just to see where the MTS13 is, so that we can actually predict whether a patient will come back for plasma exchange or not, or relapse. So the data is very strong. So if you have a low than even 20% MTSN activity, the chance of relapse is almost 70 or recurrent to almost 70%. If you have greater than 20%, then the chance is actually much lower. So.
Long, would you recommend doing regular blood film review for the quantification of schistocytes in order to monitor the patient's progress?
I don't think schistocyte is actually a good indicator. So we look at them for the initial diagnosis and then periodically, but we don't use this as an indication whether the patient, gets better or not, because schistocyte is, sometimes can be few, very few, and sometimes so it's not correlated with disease activity.
I would agree with you, Long. I think one thing I had about the ISTH testing during treatment, it doesn't give you a clear message. But I think the main thing you have to do is be careful how you interpret your ADAMTS13 and when it was obtained in the context of immune suppressive therapy, and probably more importantly, was it obtained right after plasma exchange, or was it obtained 24 hours after before the next one? Because that's really going to affect what you see in terms of the activity in the inhibitor titer. So you have to be careful and know when it was obtained.
Right. Usually we start with before the next plasma exchange. So this way you have an overnight neutralization with the residual antibodies. So.
Excellent. And one more question, Dr. Catalan, someone wanted to know the range, or what was the Rituximab dose you use?
So in general, we use the same standard dosing, 375 milligrams per meter squared, weekly for 4 weeks. There are certainly other schedules, lower dose schedule, that have been published that seem to be as effective up front. The duration of effect may not be as long, but it's not absolutely clear. I think that's sort of the default dosing. I won't tell you that's the best or required dosing. Some believe that's dosing is based on lymphoma treatment, where that much Rituximab may not be needed in TTP patients. So I don't think we know the optimal dose at this point, and really several strategies could be supported, I think.
Excellent. Okay, time is coming up, but I'll go ahead and ask one more question about, there's a couple questions on here about when would you use Caplacizumab? Should it be for the high-risk patients only up front, those with potential cardiac and neurological involvement? So that's the question. Should you be treating everyone or only certain patients with Caplacizumab?
It would be nice to absolutely know who's going to do poorly up front. And that would be a great argument to use Caplacizumab in only those with a poor prognosis or a greater likelihood of exacerbation. But you just don't know that up front. You just don't know that. So the studies are based on upfront and early use, and that's what the guidelines support. And that's the approach that we've routinely used. It would be nice to know upfront exactly who is going to do poorly, but you just don't know that. And you don't want to be in a position 5 or 6 days later where you're trying to play catch up with a drug that may not work as well if things are further down the line in terms of end organ injury, I believe.
All right. Do you have any other comments, Dr. Long or Dr. Zhang? Someone was asking when the guidelines will be published, and hopefully soon. They're being reviewed as we speak. Any other comments, Dr. Catalan or Dr. Zhang?
No, I think that's no.
No, I think the guidelines are a great starting point, but obviously more research to be done.
Yeah, I agree.
Excellent. And, you know, just like any guidelines, we always take into account patients' values and preferences. So the guidelines are meant as just a guideline to help start the conversation. I wanted to issue a special thank you to all of our presenters for their time and insight on this important topic. And we hope that you found this educational and enjoyable. As a reminder, all the webinar series are available in archive on the ISTH Academy for your reference. Please check the webinar calendar at isth.org for information on how upcoming webinars on how I treat TTP and use of novel drugs in, we're doing the how I treat TTP right now, or no, that's the next one. And then the use of novel drugs in hemophilia. So thank you for joining us and have a great day.